thank you. The question is, what challenges do Indigenous peoples face when coping with COVID? What should be done to improve these challenges? Okay, I'll start with Dr. Wieman, and then Dr. Horn, and then Dr. Lavallee.
Thanks, Myrle. I think some of the biggest challenges that we have faced, from my perspective, I should note my training is as a psychiatrist, although I now work in public health, have been the mental health and spiritual aspects of trying to abide by the public health measures and keep yourself and your community safe. But there's been a lot of talk around, people not feeling connected to one another. And the need to connect to one another in some cases has led to clusters and outbreaks of COVID-19 when people have gathered together for life events like funerals, for example. But I think we all need to remember that, the mental health aspects are there for each and every one of us. We're all living through this pandemic, and it has taken a toll on each and every person. And we're going to have to, not just talk about it now, we have to be already in the planning stages as we come through the phase of vaccination and gradual reopening, to increase, for example, mental health supports that are available for people, both on reserve settings and in urban populations. Because the mental health aspects, it's not like people have in this mind that we're just going to open up and everyone's going to go back to the way it was before. But people are going to feel lasting impacts on their mental health and their spiritual health because of what we've all been through. And we need to make sure that we have supports available for that.
Okay, thank you. Dr. Horn?
So without saying what Dr. Wieman said, for sure the mental aspects of this have been very challenging. From a primary care perspective, as a family doctor in the community setting, one of the biggest challenges was trying to maintain stability of people who have chronic illnesses like diabetes and heart disease and kidney disease and all of these other things. They still had to maintain all of that surveillance with very few supports there. And so that posed very unique challenges to the decreasing amount of personnel that we had in our health sector in the community. And so it was a very stressful time for everybody because people were scared. They waited very long to go to the hospital because of their being scared, and they and I would say that some of the casualties of COVID are not COVID itself, but the fact that people became sick because they couldn't access the regular primary care that they had been able to previously.
Yeah, thank you, Dr. Lavallee.
Yeah, thank you, and I agree with my two colleagues and friends here. One of the things that we realized here in Manitoba was that the Indigenous physicians and public health people, as well as our nurses, in fact, have been leading significantly the response to the pandemic within an environment of limited access, limited power to resources. So we've spent the last 15 minutes on a large task force table here. And I probably have lost 6 months of my life being on that particular table to ensure that our community people, First Nations, I work for a First Nations organization, that we had access to testing, that we developed a rapid response system here done by First Nations scientists who theorized what this pandemic would look like for our communities, given the social determinants of health and the persistent structural racism that limits access to resources for First Nations people. And we fought hard for 2 to 3 months to get the system going, and we did. That system still exists, and it can respond to not only an outbreak in a community, but if there's increasing respiratory disease, we have it linked. And secondly, we have access to the vaccines on average 1 month sooner than Manitobans, given the fact that there's scientific evidence of the impact of this COVID-19 illness on Indigenous peoples or First Nations people. And just so that you know, what we realize is that one of the factors that we believe influence poor outcomes for our community people is the intergenerational violence from racism and colonization. There's no other way to explain what's happening across this country. First Nations people have been at the end of this colonial war, and we're seeing it right now. The virus has spread onto First Nations people, and we see the flames go higher. So what can we do is the question. What we can do across this country and other parts of the world, we could let Indigenous people lead responses without limitation and access to resources. This is the only way it's going to work. The governmental systems that we have are structurally racist in their approach to the pandemic for First Nations people. And in fact, in many ways, we're not even on the radar. So we have to really push hard to ensure that we're monitoring what's happening to our communities. But in addition, Myrle, our chiefs and our leaders here in Manitoba have kept the virus out of our communities mostly. There certainly are big explosions going on. Lots of issues with substance misuse has escalated. And that's not because we're Indians or we're Métis. That amplification of the substance misuse is a consequence of the intergenerational traumas that many of us have gone through. They are embedded within us. And so we need to take a harm reduction approach to support our people as we move one generation to the next. But Indigenous for Indigenous, and Indigenous for everybody. We have leadership. Thank you.
Okay, thank you. Okay, these are very good. Thank you very much. The next question is, Indigenous peoples were one of the first to receive the vaccine when vaccines were rolled out. What does this represent in terms of equity and inclusion? And I'm going to start with Dr. Horn, and then Dr. Lavallee, and then Dr. Wieman. Okay, Dr. Horn.
So we received the vaccine first here in our community back in January. We were in the midst of having a very large outbreak in one of our long-term care facilities. And so we were very pleased to get this vaccine. But the narrative regarding the vaccine was very mixed in our communities. We had a lot of people who did not see getting the vaccine early as being a good thing, to try and sort of in anticipation of our numbers and the severity with which we respond to getting the COVID virus. We actually saw it as, oh no, we're being experimented on again, just like we have for a whole bunch of other problems in the past, where they did a lot of experiments on our children. And so when they rolled it out earlier, a lot of people, the narrative had to really be looked at. And there's a lot of work with trying to improve the comfort with which getting the vaccine. So a lot of time was spent on the vaccine hesitancy, and it's really rooted in what Barry was saying with the colonialism, all of our history. It's very much in our memory. It's in our collective memory.
Dr. Lavallee.
In the what we discovered was that when there are outbreaks in a lot of the personal care homes across Manitoba, we have 8 personal care homes across Manitoba, 2 in the north, I believe, and 4 in the north, 4 in the south. But we realized that the Manitoba government and the gerontologists and all the public health people did not even shine a light on what was happening in our personal care homes. And you have to remember, for some of our personal care homes, not a lot of resources, and lots of challenges. So we took it upon ourselves as Indigenous leaders to put together a team, and we now have all of our personal care homes vaccinated twice. We have monitoring of people going in and out in some of them. There's testing being done. And so we see at this point in time, in terms of access to vaccines, and Dr. Marcia Anderson is our chief scientist here for First Nations on the public health response to this virus. But right now, the current stats are that it's the majority of people who are hospitalized are non-reserve First Nations people. There are people living in the cities where there's lots of poverty, there's lots of structural racism and limitations for people in terms of access to vaccines, but also limited access to primary care. We have large sites where you could put thousands of people through. Our people just don't want to go there. So we have to develop our own clinics and our unique responses. And today, this afternoon, we're talking about using a large medical bus to go around some of the areas, the encampments where majority of people who are on the street are First Nations, to start doing something out of the box. And so I'm leading that particular response. But it was necessary. So at this point in time, Dr. Anderson has not announced that particularly, but it appears as if our efforts to deliver vaccines to the communities are reducing some of the hospitalizations. So the majority that we need to work on at this point in time are the cousins who live in the cities, Brandon, Portage, Winnipeg, etc. Thanks.
Dr. Wieman?
Yeah, thanks. And I think to add on, I guess I can make 2 points. One is, to take it up to a little bit of a higher level. When the vaccines started to become available, this was at the end of 2020, there was a lot of advocacy on coming from Indigenous physicians, chiefs and health leaders, provincial organizations, health authorities like First Nations Health Authority and in Manitoba, advocating that Indigenous peoples should be prioritized as a group when the vaccinations rolled out. I mean, initially, I don't think we were on anyone's radar when we all started out thinking about that the vaccines would be coming. This was last summer. And because of some of the particular things that put us at risk, particularly, on reserve communities where multi-generational families may live in the same house. It's much more difficult to physically distance from people. And even in the urban situations, such as Barry described in encampments, and also people living in homes in urban settings with multi-generational families. There are a whole number of reasons why we may be at particular risk of having severe outcomes if we contract COVID-19. And so that advocacy took place sort of as the planning for the vaccinations rolled out nationally. But then what happened was, it would be fine for the Public Health Agency of Canada to say, Indigenous people need to be a priority group. But what happened is each province and territory makes up their own mind about where the vaccines would be allocated. And then it was sort of an inter-provincial fight about where we get prioritized. So there was a lot of advocacy that went on, and not even advocacy, action, trying to make this happen. And we know that in different provinces that was the case. So the first vaccines rolled out in British Columbia, for example, to our most rural and our most isolated and remote communities on December 29th, I think, was the first vaccine clinic. And then the second point I really want to make is how that caused disruption amongst mainstream society and brought out a lot of racist, abuse, basically, where people were saying, well, why is it okay for an 18-year-old First Nations person to be vaccinated, but my 60-year-old grandmother or auntie is waiting to be vaccinated? And it's because people don't understand the historic and contemporary reasons why we may be at particular risk of severe outcomes, including hospitalization, intensive care, and death, but also that systemic racism piece. People, find it very difficult to go seek services. And Ojistoh mentioned this too. People are afraid of accessing services because they're not sure how they're going to be treated. So we had people waiting, with COVID infection till the very last minute, and then showing up to hospital. And of course, when you show up a bit later down that road, you may be at risk of having a much poorer outcome. So we were, achieving prioritization for vaccinations at the same time as experiencing racist backlash because we were prioritized.
Okay, thank you. The next question is regarding Indigenous peoples' self-imposed lockdown. Many Indigenous communities in Canada went into self-imposed lockdowns while their nearby neighbors that provide services for them remained open, such as grocery stores, clinics, etc. What does this mean for containing the spread of COVID? I'm going to start with Dr. Wieman, and then Dr. Lavallee, and then Dr. Horn. Okay, Dr. Wieman.
Sorry, Myrle, can you just repeat that quickly?
Sorry.
That's okay.
Yeah. Many Indigenous communities in Canada went into self-imposed lockdowns while their nearby communities, the service towns, etc., that provide services for them remained open. These are the ones that have grocery stores, clinics, etc. What does this mean for containing the spread of COVID?
Well, I think in general, in those situations that happened, I can only speak from my BC experience. Communities that went into lockdown of sorts organized trips, for example, to get supplies for the community, so that not every person that lived there had to go to the service town or the neighboring town to get groceries, for example, or people kind of gathered their lists together and only a certain number of people went in order to reduce the risk. That of course isn't necessarily sustainable, and so what I think happened after the first wave and the second wave, when things at that local level opened up just a little bit, was that as the vaccination started to roll out, we took what was called a whole of community approach to vaccination. So we offered vaccines, or working in partnership with the communities who made who made their own decision to vaccinate people who serve those communities. So non-Indigenous or non-First Nations nurses who worked in the community got vaccinated. Other people who came into the community got vaccinated, even if they weren't members of that community, but had regular contact. And all of this is, it's very variable, of course, across the country as to how people make the decisions about how to reduce the risk for themselves, their families, and their communities.
Dr. Lavallee.
Yeah, thanks. Thanks, Nel. A lot of what Nel says are the same experiences here for our communities. But what I'd like to suggest in terms of a critique of the public health measures imposed on First Nations people who live in the most impoverished environments compared to white people in the periphery of Winnipeg, who live in incredibly well-served communities with large houses. Poverty is the greatest risk factor. It's not personal behavior. And so you have to take what the risk factors you're talking about, self-isolation, all of those kinds of things. When community members are dealing with substance misuse disorders, how do you follow public health orders? When there's been intergenerational substance misuse related to incarceration in residential schools, 60 scoop kids, kids currently incarcerated in child family services, thousands and thousands of First Nations children. Now, when they grow older, they have had multiple adverse childhood experiences because their skin is brown. And how do you expect people to abide by public health measures? So I suggest that the continuous colonial colonization of Canada is the greatest risk for this virus for us as Indigenous people. These borders should have been closed a long time ago, but the ongoing need for Canada to develop this settler society is what's put us at this place. So, Myrle, in a real way, I disagree. Our communities have done the best here in Manitoba, okay, abiding by the laws. But when the majority of people, 80%, are unemployed, you're already isolated, then you want to isolate people to isolate in a house. Nel is right. Violence has gone up against Indigenous women and children. There's a neglect going on related to poverty. People in Manitoba here, we have no harm reduction. So it's First Nations people and that are actually developing a harm reduction approach so that people could have some of their trauma taken care of, and then they could get a vaccine. Then they can actually perhaps abide by the public health measures. So, you know, the close-knit communities, our chiefs took care of that. They actually applied the public health measures, and just like Nel said, and if people chose to go outside, they would have to stay away for 2 weeks or isolate. It's getting better now because we've got a lot of vaccinations out for our communities outside of Winnipeg. But we can't forget that the greatest risk factor for First Nations people is the colonially constructed poverty they live under.
So coming from a community that is divided by Ontario, Quebec, and New York State jurisdictions, but Mohawk, Ojistohhorn, we had three different, at least two Ontario and New York State different sets of guidelines. So it was actually quite confusing for a lot of people because we all use the same radio station. And so it was kind of very confusing to follow all of these guidelines, particularly because they changed daily. However, we have an excellent group of nurses who were able to carry through the public health guidelines. But like Barry and Nel were saying, we have such a wide scope, or such a degree of wealth and poverty and access and no access. We have so many transportation issues. We have so many issues on reserve that are very severe, but they're not the same set of issues that we might have in the city. Most of the people here, however, were able to, the families were able to self-isolate. We were very fortunate to have a strong community. And I think that one of the positive things that COVID did was it unearthed or showed us how strong our communities are actually when we are given our own devices to be able to take care of ourselves. It was really nice to see things like a lot of community members start to grow their own plants and start to go picking for medicines, start to do their own, do their ceremonies by themselves with their families rather than having to go to the longhouses and have somebody else do it, learning how to do the ceremonies on their own rather than relying on somebody else, you know, having to sit there and have to realize how hard it is to teach your own kids. And, you know, realizing that maybe we took our teachers for granted all those years. Just all these different things that we learned going through this pandemic, which were, for the most part, really difficult, but there were some really positive things. I would have to say that we have an incredibly large addictions problem in our community, and that was really highlighted. And what it's done is really changed our focus as the primary care sector, that we've been spending a lot of time on this chronic stuff, and now we have the protocols in place. Now let's start looking at our youth and our people with addictions and serious mental health issues. So I mean, what it did was it changed our priorities, which is always a good thing, to look at something through a different lens.
Okay, thank you.
Well, I want to just give one shout out before this goes. Okay, it's really important. I want to a big shout out to First Nations nurses across Manitoba, who are the stars of the work that we're doing. When the COVID cloud started hitting some of our communities, it was our First Nations nurses who went into teams into the COVID cloud to do testing. And this government that I work with didn't even include them in the first vaccinations. They included the ICU doctors and nurses. And so at a table one time, what I said to them, give me the vaccines. I'll reduce the admission rates to your hospitals by 50%. That's the logic. And then your ICU nurses and doctors won't be at risk because First Nations people are getting sick with this virus and ending up hospitalized. And that's how we got the 20-year difference. But my shout out is to all First Nations nurses. They are the stars. They're courageous, use science and stick to communities. From their jobs, they went in teams into communities to respond. So I take my hat off to the community of First Nations nurses. Thanks.
Yes, thank you. Those are very important, the nurses and the community responders and First Nations. Yes, thank you, Dr. Lavallee. The next question that we're going to go to, in terms of collecting data sources and surveillance of population metrics regarding Indigenous peoples. So what are some of the gaps from these processes? And how can we prepare for the next pandemic? And I'll start with Dr. Lavallee, Dr. Horn, and then Dr. Wieman.
Thanks, Myrle. And it was Dr. Marsha Anderson and the team that she works with who actually did the attachments for First Nations status to the request for testing. And that was the formation of the data for First Nations. I believe the Inuit also have that. I don't know. The Métis do not. What do we need to do for the next wave coming up? Because it's going to come again, is we need to have all Indigenous people attached to health data so that we can monitor it scientifically and find out what's going on. And that's not being done here in Manitoba. We're blind to what's happening to Métis people. We have some idea what's happening to Inuit people, but this needs to be to stop, and we need to get proper data sources for all of the health data to find out what's going on in Manitoba anyway. Thank you.
Okay, Dr. Horn.
Yeah, the issue of poor data is not a new one. I mean, it's part of the Truth and Reconciliation recommendations to provide better data for all Indigenous problems and health and good things too, so we can have good studies, you know, about, you know, things that we're doing really well. As far as how to prepare for the next pandemic, I think, you know, traditionally, when we look at our creation story, I can speak for Haudenosaunee, we talk about these parts of the world that exist that were put very far into places that we didn't interact with. And there were these buffers there. These things that would hurt us were put deep into caves and into the ocean, into the ice, into high in the mountains, places where we weren't. But as we have, you know, gone through with the population of the earth, and we are cutting down all of these barriers, and we are getting closer and closer to these things that would otherwise hurt us, we are now seeing things like COVID. So this is not a new thing. It was expected, anticipated, described in our creation stories. And so one of the best ways to get ready for the next pandemic is to start looking at our place in nature and start looking at the great balance that exists and that we have tampered with as human beings, and start to pay attention to some of those old stories that are very relevant today.
Okay, thank you, Dr. Horn. Those are very good points regarding nature, the connection to nature, about Indigenous peoples. To Dr. Wieman.
Yeah, I really like both Barry and Ojistoh's responses, because it's a real, you know, sort of Western and then the traditional knowledge and stories brought together. And in general, I think that's, you know, how we're going to manage, how we ought to manage healthcare for Indigenous people and future pandemics in general, right? We have to acknowledge that those traditional knowledge pieces and how important they are. And I think, you know, as far as data and surveillance, again, I can only speak from my own experience at First Nations Health Authority that, you know, just in general, I would say, you know, getting accurate data and maintaining surveillance depends on, first of all, having those partnerships with our regional health authorities, with our provincial government, and organizations like, for example, here in BC, the BC CDC, to be able to link data so that we know when someone tested positive, that it could be linked to our First Nations client file, it's called, and we would know that where the positive case was and who it was. And so there's a whole bunch of issues that's probably too long for this panel discussion, but to say that there has always been, since the pandemic started, a delay in making that linkage and getting us the information we need. And when someone tests positive, not being able to get that data for 3 or 4 days, and then it's even longer over the weekend, you know, time is of the essence, and that person can have many more close contacts because we don't necessarily know that that person was positive. So that's something I think we need to look at moving forward to the next pandemic. But I think the other thing about pandemic preparedness is, at least in British Columbia, you know, people had vague pandemic preparedness plans, but they really had sat collecting dust on a shelf for quite a while. So I think it's a reminder to all of us that we need to have these kinds of plans ready and have the supports ready for people when they need it. You know, as I mentioned before, like we've been providing, you know, FNHA provides, for example, isolation supports to people when they test positive or when they've been identified as a close contact, because people can't necessarily go just stay in a motel for 10 days and wait for that period to expire. They need support to do that, and they need, you know, groceries and all those types of things. So all of that to say, you know, this should really be, first of all, we should be ready for a next pandemic, because we don't know when that's going to happen. And that doesn't mean living in fear, because it's actually empowering to have those plans in place. It's proactive. That's one way people need to regard it. And, you know, the second thing is, you know, taking the lessons learned from this pandemic and incorporating them into future plans. Like, you know, there's not enough time to describe some of the initiatives, but one of the things we've done over the pandemic to help people cope is start this, it's called the Good Medicine Initiative. And we've asked communities and individuals to submit videos, pictures, stories of how they're kind of managing during the pandemic. And, you know, there's community, for example, early on in the pandemic, I remember they were a small community, and they would stand on their doorsteps every morning and sing and drum and start the day in a good way. So even though they couldn't be together physically, they were safely physically distant from one another. They learned how to modify a ceremony so that they could still have it, but be safe at the same time.
Just one thing, Myrle, about the data, and Nel reminded me of that. At the beginning of the pandemic, the chiefs, we would gather with the chiefs several times to talk about what the numbers looked like. But it was quite clear that public health in Manitoba was far behind First Nations leadership, and that the rules around access to data at a provincial level have nothing to do with sovereign states. So what would end up happening is that a cousin would find out cousin X who came by is positive. And so the chief would know that. And then so he would go to the family and to make sure. But public health in the beginning would never verify. It took us months to be able to change what they were doing so that our leaders can have the information as early as possible. And Nell is right. A weekend with somebody running around a community with seeing their friends, you get 100 to 200 contacts. And that was nothing to do with being Indian or being a leader. That solely rests on the limitations of the systems here in Manitoba. It's better now, and we are prepared. But I just want to share that with you. And thank you, Nell.
Yes, thank you. Those are very good points, because as Indigenous peoples, we don't have the infrastructure, we don't have the resources, we don't have the capacity, and we're always fighting. It seems like we're always fighting. And we yell, but we're not heard. And these are a lot of the challenges that we have to go forward with. But at the same time, like you said, we have lessons learned and what we learned from here. Okay, the next question, I'm very conscious of time here. What is the importance of coming together to collectively address COVID in a holistic and harmonized fashion based on your own expertise and knowledge? And I'm going to start with Dr. Horn, Dr. Wieman, and then Dr. Lavallee.
So the importance of approaching something like COVID in a holistic fashion, I don't know what the question is, because that's the way that it naturally should be done. I mean, at the very beginning, one of our clan mothers, she actually named it Gunhardinus, she talked about, her name, now it's escaping my mind. She gave a name to it. And this name, you have to name this problem, not COVID-19, but name it from a spiritual point or the way that you would understand it. And so this is talking about a breath or a mist, a vapor, and it's kind of going in and around us, and we're trying to keep it away from us, but it's coming in us and out of us. And it's just, it's there, it's part of us, it's part of nature. It's not going away. We have to learn how to live with it and how to protect ourselves from it, but we can never, like eliminate it. And so once you realize that you're part of this thing in nature, and that there's no way that you're going to eliminate it, you have to learn how to live with it. And how do you create those buffers that I previously talked about, that we have been, that nature set up for us. Now we have to create these other buffers, and we can do that by living in a much more healthier way, going back to our ceremonies and recognizing our place in nature, and getting our children back out on the land again, and having our elders once again participate in the teachings in a more explicit way, and having everybody start to participate in the prevention. So it's not just holistic, like your mind and your spirit and your physical and your mental, your emotional. It's not just like on an individual, but holistic, like the entire community. So the way that, like, I don't know what the question to I don't know how to answer to your question, except to say that naturally how it rolled out here in the community was very holistic. And like I have mentioned before, it really brought out some of the strengths of the community, the COVID. I brought out some of the not so strong parts of our community, but it also brought out some of the incredible strengths. And that's where I'll end that.
Okay, thank you. Dr. Wieman?
Yeah, I think just to add on perhaps to what Ojistoh has said, I guess one of the ways that we're looking at it here in British Columbia are, what are some of the, sadly, some of the negative unintended consequences of the pandemic and the public health response? And then what are some of the positive unintended consequences? Like, what are some of the good things that have come out of this pandemic? Because there has to be. When we really think about it, this has been a year and a half where our lives have been quite dramatically changed. And every single one of us, including all of my panelist friends and Myrle, we've all been through it. So as Ojistoh said, I think we have to figure out a way, again, we've talked about that reopening. It's not going to be like New Year's Eve. Our doors are not going to fling open one day and we're all going to run out and hug each other and then just carry on the way it was before. It's looking more and more like COVID-19 will be something we'll have to deal with going forward, although not quite in the way that it did, starting last year. And so one of the things we're focusing on is those positive unintended consequences that people have come to appreciate more: their ability to cope with adversity, to be innovative, to be creative about things. There's not much going on, right? So in people's lives, so in some communities, like reconnecting with, being out on the land or beading, it's sort of, in some ways the equivalent of all the sourdough videos you see on TikTok or whatever. People are sort of naturally drawn to doing things that soothe themselves. And I think we'd forgotten to a certain extent how important some of these activities are for us, for our health and our wellness, which is holistic, right? I'm not just talking about physical wellness. And so I think, we have to remember that people, that's where we get our strength from. The other thing I think that we've talked a lot about here in British Columbia as part of the sort of resilience or coming back from adversity is some of our Indigenous strengths, and including our sense of humor. That there's been so much bad news and so much negative things. It's very heavy for people. but we have also tried to, bolster people's coping by bringing out some of those strengths, including a sense of humor when it's appropriate. I'll give you a quick example. The Good Medicine Initiative, for example, we asked people to submit photos of their do-it-yourself haircuts, right? And so, we received some pretty awesome homemade haircuts, including people doing their dogs. And it sounds so silly, but really when you think about it, and storytelling, right? When's the last time we all really had a good belly laugh? How long has that been? And that's good medicine too.
Yes, thank you, Dr. Wieman. Dr. Lavallee?
Yeah, I'm not going to take long. I want another shout out for leaders in Manitoba here. I'm talking about our knowledge keepers. They came up, they were courageous, they're calming people, encouraging people to take both our traditional knowledge systems and then accept what's available to us to understand this pandemic through Western modes of understanding. So my hat's off to our knowledge keepers. They're beside us all the time. They're supporting us. They're trying to support people. We have a team of knowledge keepers, several teams actually, who actually phone people. And even in some cases, we got some exemptions when people were at a terrible point in their life. So that is positive, that is holistic. And Nell's right, we try and laugh sometimes just to get away from this a little bit because it's quite sad. But thank you so much.
Yes, thank you. That's really good. Those are really good points. We love to laugh as Indigenous peoples. We're always laughing at the silliest things. People don't understand necessarily what we laughed about, but we get it. We're going to go into the questions because of time. The first question I have here is regarding the comment regarding the pan-Indigenous approach. Would you please explain this further? As a Métis, my people and I where my family is born, borders on First Nation communities. We did not receive a priority access to vaccines, although the social and environmental living conditions are regionally the same. Maybe Dr. Lavallee, you can take that.
Yeah, no, whoever posed that question, I agree 100%.
Are you muted? Yeah.
Yeah, one of the things that we did for vaccination, and we couldn't do it in the city here, although we are coming to a pan-Indigenous approach for vaccinations, we're still in a wrestling mode right now, is that the Métis cousins who live in or near reserves in general, we know from a study a long time ago that the outcomes for Métis were probably similar to First Nations the further you go north. Now that changed and varied as people came down to the south. So yes, I agree. And although we don't have absolute scientific evidence that Métis should be prioritized, just got to look at the history and the social structure and the same limitations that Métis live under. So I agree. Yep.
Do you want to answer that, Dr. Wieman?
I think I'll leave it with Barry's response, only because I work for a First Nations organization and I wouldn't want to comment. I will say though that, I will maybe just reiterate what I said around our whole of community approach. So in certain cases in British Columbia where we had, strictly on reserve communities, but people lived right off reserve, and by right off I mean literally like 5 seconds walk off the border. We didn't go by those geographic limitations, right? The communities themselves identified who they wanted to be part of the vaccination and provided those numbers to us so that we could allocate a sufficient supply to be delivered to those communities. So some of those, we use them as a guideline, but definitely let ourselves be led by the communities in terms of who was included in that approach.
Dr. Horn?
What I'd like to say to this question, like I keep saying, we have the American-Canadian border goes right through our community. And so the approach for the vaccinations was very different on both sides of the border. And we had the, you know, appointments and, you know, making appointments. And, you know, it was a very different approach, because over there they opened an old building and an unused building, and it was like a lineup. And so a lot of our people weren't showing up to their appointments because they had already gotten their vaccinations by just going to this other place on the southern side of the community. And so we just had to accommodate that and say, okay, and find people when we had too many open files to go in the community and find people who needed to be vaccinated. So in the respect here, we were very open door on both sides of the border, and it did serve those people who needed something right away or who wanted to have an appointment. Very, I guess, accommodating to the region, the area, which is what we're looking at.
Okay, well, we have 5 more minutes. I want to ask you all again. I'm going to go with the order on my screen. Dr. Wieman, do you have any last comments?
Yeah, I guess I'll start by, you know, thanking everybody who came to the panel. I can see there's something like 87 participants. You know, these discussions always have to be necessarily short because of time, and we could obviously probably spend the whole afternoon together talking about these issues. But I guess, just want to stress that, you know, this has been such a significant event in history for all of us. And sometimes, you know, when I talk about humor, I also feel, then I say it and then I feel a little bit badly because I didn't properly acknowledge all the losses that we've experienced over this past year and a half. And I mean that sincerely, that, you know, we obviously, these are, when we talk about numbers of deaths, we're not talking about numbers, we're talking about people and community members. So we take that to heart too. And so it's been a really challenging time, I think, for all of us. And as you see here on the panel, you know, there's a real diversity in who is working away at this pandemic. We have First Nations or Indigenous nurses. We have Ojistoh, who's working in primary care on the front lines in her community. Barry and myself working at a little bit of a different level in public health, at the level of health authorities. But everybody, including community members and community leadership, doing their part. So I guess the one message I'll leave you with, and I think it is a growing issue across the country. This afternoon, I'm presenting the 2020 opioid crisis data to all BC chiefs and leaders, and to remind people that we actually have 2 public health emergencies that are going on right now: the COVID pandemic and the opioid crisis, but also a third one, which is anti-Indigenous racism. It's not a declared public health emergency, but it's in my mind, and I'm sure I see nodding, it's top of mind because it impacts both of those crises so significantly. So not to leave the panel on a downer, but just to say that there's lots to do. And we have a long ways to go when it comes to helping people in our communities who use substances. Thanks.
Okay, thank you. Dr. Lavallee?
No, I echo all of what Nel has said. There's a chronic pandemic. It's called Indigenous specific racism. It operates and holds Canada together. It holds our provinces together. And it is a framework by which early death is seen by First Nations and other Indigenous peoples in this country. So while it appears as a downer, it is truth. And if we don't talk the truth for the people who don't have the power to sit at a panel at an international gathering, then we're not doing right by our community people to fight for access, their rights to be human on their lands. And but that's all I'd like to say. Thank you.
Okay, thank you, Dr. Lavallee. Dr. Horn?
So this is exactly what I had intended to talk about when I came on here today. It was about how what COVID has done is given people an excuse to be negligent, to be indifferent, to say we can't do that because of the public health guidelines. And what's happened is these excuses have given have made our people be unable to access fairly services. And I can talk about some very specific, very sad cases of people who have died not from COVID, but definitely they died from the effects of COVID. And I would suggest that I felt very unempowered, even though I'm an Indigenous doctor who have all the credentials and experience to be able to advocate for my patient. And even though I had that, I was still not heard by the doctors and the facility with which I have worked at the interface between our reserve and off the reserve. And it is very disheartening to realize that after all of this personal, education and knowledge and work and intention, I still wasn't able to help some of my patients, one in particular who recently passed, not from COVID, but from the results of the systemic indifference to our people. So this, and so there is a real discussion that we have to have as to how our allies, our other health professionals, can support our voices when we speak up. Because even though we're saying the right things in the right way to the right people, we're still not being heard. And we need to have allies to come and stand beside us to say the same thing. And maybe we collectively can help raise the status of our voices. And so that's part of the biggest thing. The biggest fallacy of all is that we all worked so hard to be doctors, Indigenous doctors, and working for our people at so many different parts of the spectrum. And even so, our voice is not as loud as it absolutely should be. And so, and that's the next thing. How do we raise our voice? And it's collectively with people who are non-Indigenous as well. Thank you.
Okay, thank you. We have now reached the end of our time, and I want to thank all three of you. I'm so glad you agreed to be on. You have so much experience, so much expertise, and Indigenous way. Yay! I'm really honored to be able to be part of this panel to host. And thank you again. Thank you very much.
Thank you, Myrle. Thank you.